Hello, hello, hello. Thank you so much for being here with us. We're here with folks from MSF, Doctors Without Borders, to talk about an issue that is close to MSF's heart and also close to my heart, which is tuberculosis in kids. So for those who don't know, we've known what causes tuberculosis for about 140 years. And somehow in that 140 years, we still haven't developed a great test for kids. They struggle to, often they're not diagnosed correctly via microscopy. Often they are not diagnosed correctly via gene expert test because they can't produce enough sputum. And so chest X-ray is a really essential tool, but even that has its shortcomings when it comes to kids. And this is pretty shocking to me. Also, we don't invest much of our research dollars into kids. So I met with someone recently who told me that when their kid got TB, they had to crush up the pills and then kind of divide them into thirds and put them in sugar water and every day for months and months and months in order to get their kids appropriate treatment. That's starting to change, but that was the standard of care for a very long time. And I talked to someone who, in the U.S., who got TB in the 1940s, and that's how his mom treated him. And so we're talking about a delta there of 85 years. And I think that's pretty damning when it comes to how we treat tuberculosis in kids. For those who might be new here, I'm John Green. I am obsessed with and in deep hate with a disease called tuberculosis, which is the deadliest infectious disease in the world, killing over, as of yesterday, when the World TB report came out, 1.2 million people per year, a slight reduction from the year before, which is progress, but slow progress, and we're seeing even slower progress when it comes to TB in kids. So I thought this was an important moment to talk with some experts at Doctors Without Borders about TB in kids generally and what can be done and what is being done. So we're going to start with a TB survivor and the mother of a TB survivor, Ani Hernasari, who was initially misdiagnosed, which led to her having drug-resistant tuberculosis. And eventually she is a two-time tuberculosis survivor, if I'm not mistaken, and also her kid lived with tuberculosis. So Ani, I wonder if you can just start by giving us some broad outlines of your own experience with TB, both as a patient and as a parent, and about your path toward diagnosis when you were pregnant.
Yeah, thank you so much, John Green. And thank you so much for the opportunity. So my name is Ani Hernasari, and I'm TB survivor in Indonesia. And now I lead TB survivor organization called Rekat Peduli Indonesia Foundation. And my stories began in 2011. At that moment, I have caught, and I go to the doctor, and he doing the X-ray, and the X-ray said that I will have TB with specific cases. I don't know how I forgot still. And when I check my sputum, they check is negative. So I check it twice. My sputum is negative, but the doctor still give me the TB treatment. So they give me TB medicine, but I think that is not adequate. So it's not along with my body. So they give me once daily. So after I take the medicine once daily, after 2 months, I cut off blood. So they give me injection and the blood is stopped. But when I doing the heavy activity, I cut off blood again until 6 months. I think I have to go to another doctor. So when I go to another doctor, they put my sputum until 3 months because that moment we still don't have the GNS part. They found that I already resistant for 3 medicine. And that moment, I still remember the date, 11 November 2011. So that is the first time I drink the MDR medicine. And in 2012, February, I found myself pregnant. So yeah, that moment, the hardest is when I feel the 3 semester of my pregnancy and also the side effect of the medicine. So it's like become one package. I have to vomiting every day and then nausea, headache, and everything. It's like I just want to give up that time, but I still remember that one little life is depend on me. So yeah, I have to keep fighting. And then after 8 month pregnancy, because I around 7 or maybe 8 months, my water broke. So that moment I have to do the Caesar surgery. So that is the like the turning moment when they put me in the emergency room. They put me in the glass isolation, and the doctor asking me to change the hospital shoes that everybody can see me from the outside. So that is the stigma and discrimination I faced during my time to deliver. And even after I deliver my baby, I have to separate from my baby. It's like for 5 days because they put me in the pulmonary room, not in the maternal room. So, but thanks God, after 5 days, yeah, I finally can meet my baby, and thanks God that he is healthy. He drink TPT, preventive therapy, and then after a year, he got the BCG. And then in 2000, I recover in 2013. But in 2015, I taking care of my brother who get TB sensitive. But after I taking care of my brother, me and my first son get infected. So yeah, that is the second time I have to struggle for me. And then I already have two sons that time. The first son, when test is she is positive to TB, and the second he is negative. So the struggle is I have to recover for myself, and I have to being the caretaker for my kids. So the challenge is when I have to drink the medicine to my youngest, because he is still 9 months and he is still breastfeeding that time. uh, every time, even I already crush it, he always spat it out. So I have to like make he swallow like 2 or maybe 3 times. Sometimes he always throw it out like that. So yeah, that is the hard time. And but lucky me, I have a support from my family. So they giving me like spirit, because I depressed that moment because I have to uh, taking care of my body. I have to taking care of my children too, and that time make me my breast, my milk cannot. So it's like stop. So that moment, feel that the challenge is more like heavier than before, even though the side effect is more heavy for MDR. But the challenge, because I have to take care of two life and plus me. So but the spirit from my family give me courage. And when I every time I see my kids, I have to give the best the best chance for their life. So I do everything to make them healthier like now.
Yeah, well, thank you so much for sharing that story. I have a couple of follow-up questions for you. When you were taking care of your brother and he was sick and you knew he had tuberculosis, I assume, were you offered preventive therapy or was that not offered to you?
So that moment, he did not live with me.
Oh, so you
So
wouldn't have been offered TPT.
yeah, Yeah, so when he is sick, he come to our house. So
Mm,
I taking care of him. I just know when we go to the hospital that he get TB.
yeah. Yeah. So, I mean, I think this is a really important thing to say is that you can get reinfected with TB, as Ani
Yeah.
has experienced. It's pretty common actually, because if you don't solve the underlying problem, then, like of TB just spreading in a community, then people can get reinfected with it, obviously. It's a difficult disease in that way. But also that with TPT, with preventive therapy, we can prevent people from getting reinfected with TB. It's just that we don't have nearly enough preventive therapy available. So I think the most recent study showed that maybe 20% of people who should be getting TPT are getting it. And I think, if anything, that's a little misleading. It's probably more like 10%. And, so if my daughter got tuberculosis or my brother got tuberculosis and I was taking care of him, I would be offered TPT no problem living in the United States, but that's actually not the case in many high burden TB countries like Indonesia, which I think reveals some of the problems that we face as a world. Oh no, we just lost Ani. Oh no. Um, just while I was prattling on. Well, hopefully she'll be back. Um, time I want to express my gratitude to her for, oh, she's back. You're back. You were gone for a second, but now you're back. One other question for you. Can you talk a little bit about I mean, you talked a little bit about this, but the differences in taking care of someone who is sick with TB and how you see in general the role of survivors in the fight against TB in children?
Can you repeat it?
Yeah. So how you experience taking care of a kid with TB, which you've talked a little bit about, and what you see as the role for TB survivors when it comes to fighting TB in kids.
Yeah, so my experience with taking care of my both my kid with preventive TB and the eldest is with have to drink the TB sensitive drug is like it's hard for me because uh, that time I don't. I know that the pill is bitter. So when you know that is not like not good enough for you, the taste is not good for you, kid. But you have to give it. So that is like the hardest time when I have to seeing him like vomiting because after he drink the medicine sometimes he vomiting and when I see the drug is throw it out I have to make sure that he have to drink it again so as a mother it's like it's a painful for me because that moment I try to be a good mother to taking care of all my family to do like to be prevent from TB. But it's like that time I fail, even though they
Mm,
first time my kids already drink the TPT and already get the BCG when he was born, but he still like have to dealing with TB again. So uh, yeah, that is hard for me, and I think uh, the role of the survivor uh, we can be the what you call the role model for the people and for the family that maybe he don't know that he have TB and we can give them like education and then we can give them awareness about how is TB and then about how TB can infect your family and we can give them awareness about uh, how that to wearing a mask like how to make your live life is healthier with enough nutrition, like that. And we also give like advocating for the stakeholder. Sometimes we do that uh, to make sure that people on treatment get their right to get the best service. I
Yeah,
think.
well, that's really beautifully put, and I think really important. When I was in the Philippines, I got to see Doctors Without Borders work in a really impoverished community in Manila, and I met with a young man who'd just been diagnosed with tuberculosis hours earlier. And it's one thing to hear from me or from a nurse, if you take your medicine, you'll be stronger and healthier. It's a different thing entirely to hear from a survivor. Who has had that experience, who's been through it, who knows what it's like, who knows what that feeling is. And I think that's really, really important work. And I'm super grateful to you for doing it. I want to move on now to Dr. Carrillo, who's an Argentinian neonatologist and pediatrician who is currently working in Mozambique. And the tactic, which is test, avoid, cure TB in children. Man, the TB world loves an acronym. So, working on tactic in Mozambique. I wonder if you can talk about some of the challenges, Dr. Natalia, in terms of treating TB, but also in terms of diagnosing TB in kids and what your kind of daily experience is like in Mozambique right now.
Yes, thank you. First of all, thank you for having me to give me this opportunity to talk about TB. And yes, we have a lot of challenges, you can imagine, but I would like to talk about three particularly because also we have patients that are suffering this and you will understand. The first challenge in diagnosis is the children by themselves. The children sometimes they don't have the classic symptoms that we know about TB in adults, you know. So to understand this, I would like to talk about one patient, random name, but a real patient, that is Francisco. Francisco is a 9 years old child diagnosed with TB. And when we discussed with the mother, can you explain us how the disease starts? The mother literally said, he was not playing as usual, he's not eating as usual. So the mother started to be worried, to concern, and she did the consultation. So Francisco has a long journey, no? But here the conclusion is that we need to associate also these kind of symptoms, loss of playfulness, loss of appetite, weight loss, to the classic symptom of TB, fever, cough, and night sweat. Sorry. So this is a real challenge. The children are not classic. The second challenge, so sorry. The
Go ahead.
second challenge that we face, and unfortunately is very common, is the delay in diagnosis. That of course this leads us to the delay in treatment. So the delay in diagnosis could have different reasons: lack of awareness or technical skills. Also, as you mentioned at the beginning, the diagnosis tools that we have, the diagnosis tests, are not perfect. Yes, the sensitivity of a gene expert, we know that in children is not the best. Yes. Anyway, we are gonna always to ask for gene expert because a negative result also is information. So for this, or to show you the delay in diagnosis in our patient, we have the example of Regina. Regina, also random name, real patient. She's a little girl of 1 year, 2 months old. We discussed her situation yesterday in a meeting with the Minister of Health staff and also MSF, because the question was, we have this little girl with 3 weeks of fever, and her mother is actually currently in TB treatment for resistant tuberculosis. No? So the question for us was, we need to start TB treatment in this child? Yes, of course. We need to start right now. Now, the second question for me is, what about the past history of this baby? And now yesterday we discovered that we have a delay in this diagnosis. Why? Because the mother was diagnosed in August of this year, and she started treatment immediately. But the child in August, at the same time, she was hospitalized, sorry, because of malaria and pneumonia. So the baby, at the same time that the mother, she has respiratory symptoms. She has symptoms of pulmonary TB. So when was the best time to treat Regina? It was in August because she is living in a high burden country like Mozambique. She has less than 2 years old. It's a high risk children, as other children with HIV or with malnutrition. We need to pay a lot of attention in this child. Also, she lived with her mother, closely with her mother, that she has a confirmed bacteriological test for TB. So if in this case, for example, we use these new recommendations, these new tools as the treatment decision algorithm, this child can get the treatment the same day that we diagnose the mother. So for Regina, we lost 3 months of treatment. It's a lesson learned. It's something that we try to spread the message with all the clinicians because it's super important that this is not happening again and again.
Right.
And sorry, the third challenge that for us we are struggling a lot these days is the rupture of medication, of pediatric formulation. When I hear Amy talking about how she struggled to give the pill, the tablet to her child, it's not good to give the adult formulation. We face a risk. We face risk of toxicity. We face risk of resistance. We face risk that the child will not take it because it's sorry, but it's horrible. The pill like this. The pediatric formulations are made to make better adherence, tolerability. So we really need to push for this pediatric formulation. And these days, a lot of countries we are struggling with this.
Are you starting to see more pediatric formulations available, or is it still really hard?
No, we have. I will not say that we don't have, but sometimes the system of the pharmacy supply are difficult. At least in Mozambique, all this supply change, well, it's not easy.
Yeah,
You have a request still in paper or different operating systems, so it's not easy.
that's very much what I've seen in other parts of the world too. And I think, what we hear from our colleagues in other parts of the world is that while they are available, there are often stockouts or often shortages because of the supply chain issues.
Yeah.
I wonder if you can also talk about the role that you see as a doctor in how stigma plays into delays in diagnosis and TB in kids, because I know that's an important factor here.
Yes, it's totally true. Especially here in Mozambique, we have a high incidence of HIV. And why I'm saying this? Because the stigma that we face with tuberculosis is most in the cases that the child have co-infection. Yes, when they face the HIV and TB, it's harder for the families, it's harder for all the community. But other thing that also we are facing, and I can say that sometimes is higher than the stigma, is the lack of information in the community and also in the health staff, in the hospital, in the community health centers. We have some new tools of diagnosis, we have better treatments, but the people don't know about this. So if we don't know, we are not asking for this. So it's very important that the families knows that they can have the tools for testing. So it's easier to get a stool from a child. No, it's nothing complicated. It's better than the sputum. Also, the treatment. Most of the people still think that we have 6 months of treatment, and for children, we have a group of eligible children that can be a big group that we can give 4 months of treatment. So imagine for a family, 6 months or 4 months is totally different. So if we encourage the families to say, look, this is not too long, this is 4 months, we are going to make it, we will be with you. Okay, it's different. So the information is power and need to be with the community and of course with the health staff, no? All the clinician, nurses, all the staff.
Great. Well, that's very helpful. And thank you so much for that information. I do think it's really important to focus on not just the biomedical parts of tuberculosis, but also the kind of psychosocial parts of tuberculosis, because if we only see tuberculosis as a disease that is treated medically, we often miss a lot of why people struggle to finish their treatment, or why we see so much late diagnosis, or why people are so afraid of having tuberculosis. So I think that's a really important and helpful information. I want to turn now, if I can, to Dr. Mariama Mahmoud, who is the head of I want to get this title right, Program Manager for the National Leprosy and Tuberculosis Control Program under the Ministry of Health and Sanitation in Sierra Leone. Dr. Mariama is one of my personal TB heroes, because she's doing such incredible work in Sierra Leone, a place that matters so much to me and to our community. And so I'm very grateful to her for joining us. And I wanted to ask you, as somebody who works within the government, as somebody who works as the manager of the National TB Program, what are the big challenges that you see in making sure that every kid with TB can access not just care, but also adequate diagnostics?
Thank you very much, John, and I'm very happy to be here. If I would look at, I'm happy I followed Dr. Carillo's talk, because if we could look at implementing or taking these guidelines into the field, I would say I would divide these challenges into 3 sections. You have the first challenge is getting the cases, so finding the cases and diagnosing them for children. So Sierra Leone is a high TB burden country, and by that, that means we report over 10,000 cases a year. As of 2024, we reported over 22,000 cases of TB in Sierra Leone. And of that proportion, the estimates are that 15% are supposed to be childhood TB cases. Over the past few years, we have not been able to hit that 15%, and we've barely managed to get to 9% of cases as of last year. So this means we miss about 3,000 kids with TB every year. And the young kids that are 0 to 4 years old are grossly underserved. We have not hit that target a lot. And a lot of it could be attributed to the diagnostic challenges that Dr. Carillo already mentioned. But even within the districts, we have issues with low, healthcare workers have low confidence levels in diagnosing childhood TB, which could be linked to training and adequate supervision, because it's mostly clinical and a lot more subjective than we'd like to assume. There's also very poor access to the diagnostics, the gene experts, the chest x-rays. The chest x-rays, we already talked about the gene expert, the stool testing, but then these machines are not everywhere. So which means even if you have a sample, you have to get it to a machine to get tested. And we rather move the samples than the patients, but there are still challenges with that. The X-ray machines we have are also very sparsely distributed, often dysfunctional, and even when they're functioning, access to that is mostly problematic, because for that, you cannot move a sample, you have to move the child to the X-ray machine. For MDR-TB, it's even more dire, because we only managed to diagnose less than 1% of our cases of MDR-TB last year. There's also gaps in prevention and treatment. We're talking about TPT. We have a target of 90% of all children under 5 that are contacts of TB to receive TPT. We've only managed to achieve 2.8% of that. So it just shows the challenges that we have actually implementing some of these guidelines. Dr. Kaila also mentioned the 4-month regimen for children. It's ideal and it's very good, but it also has challenges in excluding. You have to exclude severe TB. If we have limited diagnostics, limited healthcare worker capacity to diagnose that, then that means we're not very confident on who to put on a 4-month or a 6-month regimen. So this is just the implications of policies and practice. Also, we don't have TB screening routinely embedded in child and maternal health services. We're trying pushing for integration now, but it's not optimal yet. So we're missing a lot of kids that actually come to the hospital, but they are not diagnosed with TB. And lastly, we want to talk about the systemic and structural barriers. You already started talking about that, John. There are broader health system issues in settings like ours that impede equitable access for children to care, to getting care. You have poor contact tracing or contact investigation. We rely on more passive case finding. That is, the parents or caregiver has to bring the child to the hospital instead of us going out to find active cases of TB. We also have very limited availability of specialists. If we talk about the X-ray, interpreting X-ray machines, X-ray images, or just care for complicated cases, or pediatric MDR TB, these are all lacking. And then we come to the financial and social support gaps. For Sierra Leone, under 5 care is free. Children under 5 receive free healthcare. But of course, there are lots of financial barriers that persist. Apart from specific enablers that we give to MDR TB patients, there's no enablers for TB care, no DSTB care, and there's no social protection whatsoever for people affected by TB.
Yeah, no, I think
the catastrophic cost of care to the families is quite great and can impede treatment adherence. So in a nutshell, if I want to sum it up, I'll say the current system looks like a sieve. It could be seen as a sieve with large filters or large holes. So while we have these new guidelines, new drugs and diagnostic that are the filters, the sieve itself, which is the health system in general, is too weak and inconsistent. And this means that we allow children, especially those that are the sickest or the most vulnerable, to seep through these gaps, and they remain undetected and undiagnosed.
I really appreciate that kind of honest analysis of where we're at in terms of the fragility of the healthcare system and how that affects especially kids with TB. I want to ask a couple follow-up questions. You know, you've told me before, if I'm not mistaken, you told me a story that has stuck with me about one X-ray machine and how difficult it was to repair one X-ray machine and how long it took and how frustrating it was and how it meant that patients had to leave the TB hospital and go to a different hospital to get their chest X-rays, and how that involved its own set of risks and its own set of stigmas, because, you know, and I wonder if you can talk a little bit about that, about the functional challenges of making an X-ray machine work when it breaks.
Yes, so I think we had that conversation because that has been something that had frustrated me for quite a while. So our system is mostly donor funded. TB healthcare is mostly donor funded, and this means that these machines are procured by donors and usually maintenance by donors. So if one breaks, or when one breaks, because they always break, we have to then go back to said donors to get these machines fixed, whether it be under a warranty or just buying parts for the machine. We had issues with batteries for our X-ray machines for quite a number. It took like 2 years, almost 3 years, to get these batteries for these machines fixed. And this means that if a patient at the referral hospital at LACA, for example, already admitted, already receiving care, needs a chest X-ray badly for either diagnosis or to streamline their treatment, we have to move that patient to another facility that doesn't offer free chest X-rays. They prioritize their own patients, and they generally do not want TB patients in their facilities to receive care because they have other patients there. So this means that we have to move said patient to another machine, firstly secure access to that machine for that patient, and then moving these patients. These are very sick patients admitted with lung disease. So some of them cannot be without oxygen for a long time. So this means that if we have to move a patient, we have to think about the oxygen support for them, to and fro. You have to have care to a nurse to be by their side, and these are not always readily available in reality. So just a machine breaking down or batteries that get faulty batteries of a chest X-ray machine can have dire consequences on the ground for these actual patients.
Yeah, I think that's really important to understand that, we're talking about 2 years for batteries, 2 years of patients not at the TB hospital, not being able to access chest X-rays at the TB hospital. And that's a real indictment to me of the current way that donor-supported aid happens, that, there are so many hoops to jump through that we end up in a situation where there's no chest X-ray machine at the TB hospital, which is beyond absurd and should be something that, like, when we talk at the sort of 30,000-foot level about the future of aid, we need to be remembering that if the future of aid doesn't include batteries, then there's something deeply wrong with the future of aid. The second thing I wanted to ask you about is preventive therapy, is the TPT rate. So you said that the goal is to have 90% coverage for TPT. Right now in Sierra Leone, it's at 2.8%. That's partly due. Can you talk about why that is and what the challenges are when it comes to providing TPT in a really fragile, challenging healthcare system?
Yes. So for TPT, we firstly have to find the contact, and that's where active case finding comes in, or contact investigation, contact tracing comes in. So we actually have to find the contacts of every TB patient, specifically children. So that is the first challenge, getting these cases that are contacts to put on TPT. The next challenge would be, actually, if we actually find that case, we have to exclude active TB. So we have to make sure that they don't already have TB before we can put them on TPT.
Right.
That brings out its own issues of access to diagnostics, the expertise of the clinical team, etc., etc. So there's that big bottleneck as well. And then even when we exclude active TB, the drug formularies are not always very welcoming for kids, as we already started mentioning. For one of the drugs that we use now for shorter TPT, that shortens the TPT to like 3 months or less instead of 6 months, like the rifampicin, we don't have that in a child-friendly formula for kids less than 2. So this means that kids less than 2 have to be subjected to the 6-month, mostly have to be subjected to the 6-month therapy instead because of all these challenges. And another one is getting a caregiver or a parent to give a very toxic, potentially toxic drug with a lot of side effects to a kid that's not sick is another challenge by itself. Just trying to get them to understand the necessity of giving a child a drug for 6 months that has a lot of side effects, and that child is not sick. So it has not also been very welcoming in the community in terms of getting TPT going. So I would just highlight those ones for now as some of the big bottlenecks.
Yeah, those are big challenges, though, and it is really hard. I mean, if you told me my kid had to take 6 months of medication and they weren't sick, it would be very confusing to me. And so I'm sympathetic to how challenging that is. I think that's where someone like Ani comes in, who can talk about the experience of having done it and having that voice of survivors in the lives of people living with TB or people affected by TB can be really, really profound. But again, that's extremely hard in a world where you go 2 years without batteries for X-ray machines. Well, thank you so much for that incredibly helpful overview of the situation in Sierra Leone when it comes to TB in kids. It's always really clarifying. The last thing I wanted to ask you, if I can, is if you can tell us whether you are facing impacts from the international global health cuts from the US and now also the EU and the UK, the extent to which you're seeing that impact the experience on the ground in Sierra Leone.
Thank you, John. And yes, that's a very big yes. For a program that is mostly donor funded, any cuts already, even with full quote unquote support, we have all these challenges and gaps. And now Global Fund that supports over 90% of TB services in Sierra Leone have cut back 12% for this current allocation. And because of that, we've tried to reprioritize activities. And reprioritization has included, they say we should do only life-saving support or life-saving activities. And this means reducing outreach activities, reducing staff training and supervision, and patient care and the extra support to patients. So the enablers, we have had to cut back, even though it's just MDR-TB patients that we give enablers to, that even that we have had to cut back on because of the funding cuts. So activities that include community sensitization and advocacies, like Annie would actually give a testimony, or we use TB survivors out there, have had to be cut back because they're not considered life-saving. So, and for me, I think that's also life-saving because it's preventive and community engagement activities, which in the long run would help us with curtailing the TB outbreak, we could call it, in our communities. Also, we've had to cut back on data collection, strategic planning methods, evidence-based research that we've planned on doing. We've had to cancel or postpone certain surveys or research that we want to do, such as a drug resistance survey, which is very important to know what the resistant patterns are like in country. A stigma assessment survey, we've never had those. We've planned on doing that, but we've had to cancel it to just see what the effect of stigma has in caring for our patients. We also wanted to do a catastrophic cost survey to just see what it's costing our patients to get to TB care. So all of those have been cut back. And this also weakens the sustainability efforts that we've been planning on, and also increases donor dependency.
Yeah, in chat, Benedict Cumberbatch has made a great point, which is, imagine if we stopped funding traffic lights because they weren't directly life-saving. They're only indirectly life-saving, and that feels like a lot of what the cuts have been to is things that are really obviously essential, like outreach activities and survivor advocacy that we've all seen on the ground makes a huge difference for the lives of people affected by TB. So thank you so much for that. I want to turn now to Dr. Hewison, Dr. Kathy Hewison, who I want to begin by asking, well, first I should introduce, has been with MSF since 1997 and is a tuberculosis advisor in MSF's operational center in Paris. So Dr. Hewison, can you talk to us about why it's so difficult to diagnose TB in kids and what can be done to improve this? We've been circling around that question, but I don't think we've directly addressed it.
Yeah, look, I think you've got some good inputs from Dr. Natalia and Mariama, but the first problem is the nature of tuberculosis in children. Children get sick with very few bacteria. It means that the tests that we have, which were made for adults, just can't detect that many bacteria. So more than often, the majority of children will never have a positive test, which means that clinicians have to really use their clinical skills to be able to diagnose TB. And then they need to dare to treat TB without a confirmed diagnosis. The other reason is the tests that were developed for adults rely, a lot of them, on adults coughing up sputum, coughing up from the lungs samples to detect the bacteria, which small children just swallow anything that comes up, and there's no way you can get them to cough into a pot. So again, it's the tests that are based on a sort of an adult model of tuberculosis. And the last reason is what Natalia very well described, this atypical nature of tuberculosis in younger children. So if you don't think TB, you have to think TB. If you don't think TB, you'll never find it in children. But I think now that we understand some of the problems, I think the solutions are fairly obvious too. Children are the most vulnerable and are always the last to be thought about. They're not prioritized. They're never prioritized on a global scale, on many, many scales. The test is a good example. You know, we have tests for adults that are suitable for adults, but there's never been a test developed specifically for children for the nature of TB in children. And it takes a political will, sort of an awareness that this is a specific problem to confront the problem. And until we prioritize children, whether that be in research and development for better tests for children, or whether that be in funding to pay for things that are specific for children. We do have children's formulations for all the drugs for kids now, but they're a bit more expensive than the adult ones. So when you're a program manager and you have to deprioritize and you don't have a lot of kids, you go for the adult formulations. And if you're under a diagnosing and you've been ended up throwing away some expired drugs, you're not going to buy them again. And you get into this sort of vicious circle of not ordering drugs because you're not diagnosing enough. But not just in research and in implementation, but also in the whole, as you mentioned, the whole psychosocial impact. Nutrition is has a huge effect on TB in children. In fact, it's the number one determinant, if you like, of TB in general, and children are the most affected. So nutrition is prevention for TB, but because we're not prioritizing that as a preventative treatment for TB, it's not being used as a preventative treatment for TB. So I think that the access to the currently available tools, recent development for new tools, addressing all the different things that impact on kids, it's a question of prioritization and thinking TB. So I think what we can do, the most important thing to do is make sure that the people making decisions on where money goes, the people making decisions in programs, and the people on the ground and families and communities can all think about children as a priority for TB care.
I want to highlight two things that you said. First, that food is medicine, which I think is so essential to TB care. My friend Henry in Sierra Leone, who survived multi-drug resistant TB, credits his doctor, Dr. Jérôme Tefera, an incredible TB doctor, for saving his life. But he also credits his mother for bringing him extra food. So many people are abandoned by their families when they get sick, and Henry wasn't. And it's because he wasn't that in his experience and his feeling that is part of why he survived. And the second is the importance of treating, as one MSF doctor, one young MSF doctor told me in Manila, the importance of treating the person, not the lab.
Yeah.
So often we treat the lab result, not the person. And it can be clinically obvious that someone has tuberculosis. And if they have a negative gene expert test, that can cause confusion. But especially with kids, a negative gene expert test might not tell us very much.
Exactly. You got to dare to treat. Yeah.
I have a couple follow-up questions. One is about diagnostics. So there's been a lot of talk about this new cheek swab test, which is supposedly going to be much less expensive, in addition to being better, which is rare that we get a test that's better and less expensive, and really, really promising it sounds like. Can you talk about what we know about that and what it might mean for kids, or if that's
I can talk to you about a sort of generation of new tests coming out, specifically tongue swabs, for example.
Tongue swabs, not cheek. Thank you.
And it can also these tests can also work on sputum swabs as well. You take the coughing up the sample and you swab it, or you swab the tongue. The real advantage of this new generation coming out is that they're mobile. So they're as big as the palm of your hand, run on batteries. And so if you think about a setting like you were in Manila, where we're actually screening people with X-ray in the street, and then we're sending their sputum, their specimens off to a lab, and then 1 week later we have to find them. But Imagine if we could do that test there and then. It's also much quicker, these tests. The test that we're using currently takes about 2 hours. This test takes between 10 and 30 minutes. If it's positive, it might be positive after just 10 minutes. So that's a real game changer. People will wait for that result. Plus, you can take the machine to them. So when you're doing this sort of outreach stuff, you can take the test to the community. So these are great advantages, and cheaper. The machine is much cheaper, 1% of the cost of the current machine, and the test is half the cost. However, there's never anything that's perfect. There are some caveats there. So it's not quite as good as the test that we have on sputum samples. And if you use the tongue sample, it's not quite as good in terms of detecting the bacteria, that's for sure. Although, because you might actually get more people who can give some sample, because everybody can do a tongue swab, not everybody can cough up a sample, it might come out even, but that's in adults. It won't fix the problem that we have in kids, that kids don't have a lot of bacteria. It's not better at finding bacteria than the test we have. So it's not going to fix this problem of trying to find these small amounts of bacteria. What we really need are tests that have been made with kids actually in mind. So, it doesn't rely on sputum samples. So a tongue swab would be great, but also is perhaps not even trying to detect bacteria. Perhaps it's trying to detect some biomarkers or some other indication that there's TB, because that's the problem with kids. Yeah, I hope that explained it.
That explains it very well, and it's good to know, although disheartening, that it won't solve the problem. How, in general, can we better protect kids from falling sick in the first place?
Yeah, look, we do have lots of options. First, children should be vaccinated at birth with BCG. Unfortunately, it does protect very well young children less than 2 years old against the most severe forms of tuberculosis, including meningitis. So that is great. But there's no protection that goes on in life. So new vaccines are in the pipeline. So we're fully excited about that and looking forward to seeing how they can really perhaps bend the curve on this epidemic. Then there is the preventative treatment that I think Annie and Mariama have talked about, with all the challenges they've talked about, excluding TB, finding the contacts. I think, John, you were in Manila. You saw how hard it is to go to people's houses and find everybody, try to get everybody who's been in contact in a household, examine for TB, have exclude TB, then offer this TB preventative treatment to people who are at risk, and then get people who are well to take drugs for the duration. So this preventative therapy is a great tool. The good news is that there is now formulations for even the smallest kids, so that is good. But there's a lot of challenges that we've already heard about. And then the last thing is nutrition and the whole social economic situation. So nutrition is really important, and WHO has very recently put out a new recommendation that all household members of somebody who has tuberculosis should receive food support. This is irrespective of if they're malnourished or not. Everybody should get food support as prevention in food insecure settings, which for us is everywhere that we work. At least everybody should be getting that, because it's a great prevention. It's also a good incentive perhaps for the family to follow a treatment, but it's great prevention because it improves the immune system. And then the general sort of socioeconomic situation, TB is often a disease of poverty, and when people are living together, whether it be in displaced camps or urban settings, when people are really living close together, then there's a lot of transmission of tuberculosis. But I think we do have a lot of things we can do. Again, political will is lacking.
Yeah, I mean, I think that's a great takeaway for us today, is that this is a question of prioritization and political will, a decision that will be made by all of our governments together about whether or not to prioritize kids with TB and TB more generally, or whether to prioritize other things. And that's why the work of TB fighters is so impressive to me, because they really have made a big difference when it comes to prioritizing tuberculosis care. And that's why I think this conversation has been so important, is because it's a reminder to us that when we're talking to our leaders about prioritizing TB, whether that's on Capitol Hill in the United States, or in Ottawa, or in the UK, or in the EU, wherever or wherever you live. If you're lucky enough to have a say in your governance, which not all of us are, but if you're lucky enough to have a say in your governance, taking advantage of that opportunity is really important and makes a big difference. We've seen that with the, disappointing, but could have been more disappointing initial drafts of the U.S. Aid budget for 2026 and beyond. We've seen that with Canada's pledge to the Global Fund, that we can actually make a difference. It's hard work. It often feels like it isn't really impactful, but it can be impactful. And so I'm very grateful to everybody in this community who's doing that work, but also to all of y'all for doing the real work of providing TB care to the people who need it most, and to the most vulnerable among us, which is always the kids among us. So thank you very much for being here. Thank you also to the folks running the stream behind the scenes. We really appreciate it. The last thing I want to ask you, Dr. Hewison, if I may, is where you find, and maybe this is a question for everybody since we have a couple minutes at least, where you find hope, because this is very difficult work, and I'm sure that it's very discouraging often. It's got to be hard to be the head of a national TB program that's perennially under-resourced. It's hard to provide care. It's hard to provide help to survivors. So where do you find hope? And maybe I'll start with you, Dr. Hewison.
Yeah, thanks, John. Look, I think any clinician will say we find hope when we see one kid get better. It's a transformation you can't believe. A malnourished kid that looks like he's about to die, and a few weeks later he's happy and smiling. I think that's always our best incentive. But from my current role, I would say tactic at the Test Avoid Cure TB in children, we've had such a incredible buy-in from people going, yeah, you're right, this is something we want to prioritize and we want to put our energy behind. So I think that that's a real incentive for me. Thanks.
Dr. Mariama?
Thank you, John. So in addition to Kathy's hope with the patient, I would say it's the community movement that we're seeing now for me with TB care. TB used to be a very neglected and stigmatized disease, and having been working in the field for a long number of years, I've seen the transition that has taken place in terms of community ownership and engagement for TB. I think in such a platforms, we're destigmatizing TB a lot, and there's a lot more conversations now around TB. So for me, that gives me hope, because that means we can do something about it. We are not neglecting it anymore. We're actually bringing it out to light, and a lot more people are rallying around getting care for people that actually need care. So that gives me hope. Thank you.
Thank you. Dr. Natalia?
Yes, for me, related with what Dr. Mariana is saying, I found hope in the people speaking out, talking about tuberculosis. This will make others think about tuberculosis. So we can spread the message. Tuberculosis is curable. Tuberculosis has new tools of diagnosis, has better treatments, and new vaccines are coming. So we need to talk about tuberculosis. There is my hope.
Thank you. And Ani, we'll leave the last word for you.
Yeah, thank you. So I can find hope when I can see every mother having clear information about TB. And also I can see hope if every child can eventually diagnose and get the treatment. And then I can see hope when every family care that sees them not as a case, but as a human being.
That's beautiful, beautifully put. I think that's wonderful. It's so important to see people not as patients, but as human beings, not as statistics, but as people whose lives matter as much as any of ours. And so that's a really beautiful note to end on, I think. I'm so grateful to all of you who were in the chat with us, and also so grateful to y'all for being here with us and sharing your expertise on TB in kids. And thank you very much. And as they say in our hometown of Nerdfighteria, don't forget to be awesome.